Hey, John.
Let's start with a silent prayer as suggested by Sujit. Okay, thank you, everybody. So I just quickly, we'll start off. I welcome you all to this wisdom trail. Thanks again so much from the bottom of my heart to Sujit. I'm sure he's taken such a lot of pains to organize these things. I'm just around to actually watch you all guys and then.
So shall we just honor him and have a few words
Yeah,
from Dr. Anil?
Yes, just
yeah. I mean, go ahead.
yeah. Thank you, sir.
I heard your
Uh,
voice, but I didn't see you.
yeah, I'm driving. That's why.
Oh, really?
Okay,
Okay.
okay. Anyway, I think this year we have taken the decision to KOA has taken decision to bring all these subspecialties together under the platform, and I think ASK was one of the earlier organizations which has come, and we want to not the specialties to go off from the parent organization Kerala Orthopedic Association. So we are taking all the specialties. Now pelviastabular is coming. The Shoulder Elbow Society of Kerala is also joining, and the new Foot and Ankle Society of Kerala is also being formed under KOA. So it's a great thing that all these subspecialties are coming under Kerala Orthopedic Association, and I wish all the best for ASK for all its endeavors. And I promise that Kerala Orthopedic Association will be along with you in all your endeavors. Thank you.
Thank you so much, Shanin, for your kind words and your vision about KOA and all, and your and that you're welcoming us all to come under the KOA is also a great gesture, I suppose. And
Thank you, sir.
yeah. So quickly, um, I'm sure John would have to say something as he's coordinating this meeting, but just a few words. This multiligamentous injuries of the knee, as usual, is always a very contentious topic, which gives rise to a lot of controversies, arguments, and like back and forth, like which do you do first, which do you do last, why do you do at all? These kind of questions, and that's because it's like the even though you have a topic called as a term called as a multiligamentous injury, we nobody really knows what all it encompasses. I mean, because it's like a polytrauma case coming to the emergency department. So you could like go on and on with this, but we have Sujit and the people here. Thanks to them, they have selected just three topics. One is like how you image this, and Rajanish, who's been, I'm sure, doing a lot of posterolateral corners, how you deal with that, and how you plan the treatment by Dr. Pradeep. So we'd rather stick on to the topics that are being presented, and if we have time, we could probably digress to the other controversies in this multiligamentous injury. I suppose that would be the easiest way to go about today's wisdom trail. Dr. John, now can you please take over? Thank you.
Thank you, Schiller sir and Sujit for putting me as the coordinator for this program. I'm actually traveling in the train, so there will be might have little issues of net. I don't know. Hope I am audible.
Yes, you
I still remember, giving the Silver Jubilee KOA oration in 2017 at Kannur. My topic was this multi-ligamentous knee injuries. So this is a very hot topic, and a lot of evolution has happened, which we all have seen in our era. What even when I started doing multi-ligament, that entire protocol has now changed for my treatment. So we'll hear from the experts what is latest, and definitely it will be of real use in your clinical practice. Over to Murali to start how to go about.
Thank you, Dr. John. Good evening to you all. First of all, I place on record my gratitude for having selected me for this particular topic. My thanks goes to KOA, ASK, Sujit, and all the organizers behind, and my respects to all the pioneers in the field. So here we're looking at a knee with two good ligaments. We expect all our patients to be like this after we treat them. But for that, imaging of multiligamentous injuries of knee. Now, when I talked to Dr. Sujit regarding the topic, I think I gave him the notion that it is. So I thought I gave him a concoction that it was easy, but the only part that is easy about it is easy to miss these injuries. So I will be talking from what is normal to abnormal, and we should have a working knowledge of the mechanism of injury to understand the MRI. The eyes only see what the brain knows, and it's always good to sit with the radiologist and make it a learning curve come easy, because the radiologists usually miss many of the multi-ligament injuries. And do not read the report. It's a sincere request from me, because only if we see the image ourselves, we will understand what it is. So without much ado, I'll go to the corners, because we know the centers. Now, multi-ligament injuries is all about the corners coming together with the centers and failing together. And when they fail together, the patient is not able to have a stable knee and not able to wind up himself. So in the posterolateral corner, we have got the static and dynamic stabilizers against anterior and posterior translation, varus stress, and external rotation. So we have got the fibular collateral ligament, the popliteus tendon, and the popliteofibular ligament. Then we have the fabulofibular ligament, the arcuate ligament, and the capsule. The popliteus and the muscular complex and the biceps femoris are the dynamic stabilizers. Now, if you see this anatomical picture, this is exactly what is going on anatomically. So we have on the left side, we have got the oblique lateral image. We can see the lateral collateral ligament. We can see the popliteal ligament, and we can see the popliteus. We can see in the middle image the popliteofibular ligament very clearly, and the popliteus, its tendinous origin and this muscular insertion down. And then we can see the popliteofibular ligament once again here. So how do we do this in the MRI? So first we will go to the popliteus muscle. See, this is the coronal image which shows the anterior popliteus attachment in the popliteal groove in the left side image. And in the right side, you can see posteriorly the actual muscle coming down. This is how the muscle actually sees in the MRI. If you know the actual MRI visualization of the anatomy, then we can understand what is abnormal. So once we know this, we can see inferior medial course. We now know that this is the complete tear of the popliteus on the left side. You can see the fluid there inside the muscle and its expansion, bulbous expansion. Here you can see a tendinous avulsion of the popliteus tendon, and there you can see the X-ray that shows the bony popliteus avulsion. So I'll go anatomy by anatomy, the structure by structure. Now here you can see the popliteofibular ligament. It arises from the fibula styloid to the popliteus, just proximal to the myotendinous junction. In the left side image, you can see there is a oblique sagittal image which shows the full ligament. There you can see the ligament in the middle, and there you can see in the coronal image from the posterior aspect, you can see once again it crosses just above the myotendinous junction of the popliteus. Now here you can see now very clearly the tear of the popliteus above, and which is denoted by the arrow, and the popliteofibular ligament tear by the arrowhead. Now, biceps femoris. Now you can see here the biceps femoris with the two heads inserting. It has got several ramifications. It has got a ramification from the smaller head to the adductor tubercle. Not going to that. Now here, if you know the actual anatomy, you know what is the avulsion. Clearly, you can see the avulsion here on the right side. Now, you can see the normal fibular collateral ligament here, and you can see its attachment to the fibula and the condyle. There you can see in this image, in the superior image on the right side, you can see a proximal tear, and in the right side image, you can see a mid-substance tear, And here you can see a distal avulsion and proximal retraction of the fibula-collateral ligament. So if you know the correct radio anatomy, you know the radiopathoanatomy also. Now the anterolateral corner is a superficial and deep portion of the iliotibial band and the capsular fibers and the anterolateral capsule and the infamous or the famous anterolateral ligament. Now here is how you see the iliotibial band on the left side as a normal structure. There you can see the ITB tone, and there you can see there is a distal avulsion with the proximal with the retraction. So this is clearly seen. Now here you can see the femoral and the tibial attachment of the capsular fibers. You can see there are two types of capsular fibers, respect to the proximal and distal capsular ridge in the femur, and here is the anterolateral ligament, the ALL. So ALL. Now the ALL. Now you can see that it is the lateral reinforced of the ACL, and there you can see a normal anterolateral ligament with its femoral component and the shorter tibial component. So now the posteromedial corner. Now this is very important because we are always bothered about the posterolateral corner. The posteromedial corner sometimes we miss, and many often when you miss, it destabilizes the knee joint. Against valgus stress, it's a very important support with external and internal rotation and anterior and posterior translation of the knee. The main dynamic stabilizer is the semimembranosus with all its 5 arms. And the most important static stabilizer is the posterior oblique ligament, the ligament of Winslow, and then the oblique ligament, which is the entirely bilaterally symmetrical structure. It reinforces the posterior as well as the lateral aspect and the medial aspect from behind. And then you have the capsule and the on of the meniscus. So these are the 5 aponeurotic expansions, and you can see them here. You can see the superficial and the deep MCL, and you can see the posterior oblique ligament and the arms of the semimembranosus into which it reinforces. You can also see the MPFL, which I come for the anteromedial aspect shortly. Now here you can see an image which clearly shows in the axial, in the coronal, and the sagittal, the oblique posterior oblique ligament, the POL. You can see that. So if you know the anatomy, radio anatomy, the pathoanatomy is easy. AMC, as I told very clearly, the MPFL is the most important stabilizer of the AMC. Now, once we know this, we are now going to the imaging. X-rays, the most important thing about the X-rays is the stress X-rays. If you know to take the stress X-rays as 20-degree flexion for the anterior, and here what I have not shown is the lateral X-ray in the standing and the kneeling down position, because I think it will be painful for the patient. This is the X-ray of a arcuate fracture of the fibula, which is without stress, and with stress you see how much of there is a stress distance increasing. So this is the arcuate sign. Sonography is limited assessment of vascular injuries with color Doppler and peripheral nerve injury with high frequency probe. These are the 2 indications for sonography. Computer tomography, you can evaluate the complex fractures or dislocations and the popliteal artery occlusion here. So with a CT angiography, you can clearly find it out. Now MRI is the gold standard. Ideally, to take a MRI, it should be the subacute phase. Now these are the 3 things that are important. You need 2D proton sequences, fat suppression sequences, and oblique planes. Oblique planes, why? Because many of the ligaments that pass across the knee joint don't pass in the actual sagittal and coronal plane, they pass obliquely. So if you know which oblique plane to take, you are standing in tandem with the ligament. Now, I will take one slide to talk about knee dislocations, because dislocations are the final end of all these multi-ligament injuries, and they are high grade, classified by Schenke. We will go into different examples in the following slides regarding all these ligament injuries. But this is very important, the ultra low velocity dislocations which are seen in obese patients. Now, there are papers which say very clearly that there is a very high incidence of 1, peroneal nerve injuries, 2, vascular injuries, and 3, complications after surgeries like reoperation, infections, and joint stiffness in all these obese patients who have got ultra low velocity KD. That's a very important point to take over. And so now we come to the KD1. You can see there is a ligament injury with ligament injury, you can see the ACL and you can see the T1 and the T2 weighted images. You can see the injury very clear. Now, KD2, you have got both the ACL and the PCL injured and with no peripheral injuries. There are no corner injuries. In KD3, it can be either a KD3 medial or a KD3 lateral. For example, here you have got a KD3 lateral injury where you got full thickness ACL tear. You can see the asterisk. You can see a low grade PCL tear. And you can see here there is a full thickness ALL tear, anti-longitudinal ligament tear, in the figure A. In figure B, it's another patient where from the posterior aspect you can see a very high grade posterolateral corner injury with structural discontinuity of the lateral collateral ligament, the popliteus, and the distal biceps femoris tendon. Now here you can see in the right side a common peroneal nerve injury where you can see all the fascicles are distorted. It is purely white as compared to the tibial nerve, which you can see has got all these fascicles and normal signals arising from it. So if you know these injuries, if you then you find for them, then you will never miss them. Now here you can see a patient who has got a ACL injury there in the middle. You can see the ACL injury, and then he has got a biceps femoris avulsion, and then you can see a fibula collateral ligament tear, which is thread by the arrow, the striped arrow, and the black arrow shows the injury of the popliteus tendon, and also you have got this particular one that is staying just above the arcuate, the tubercle of the fibula, the popliteal fibular ligament injury. And once again, the population, the PFL, the arcuate ligament injury is shown in the right image. So if you know these, where to find for what, go near the tibia and the fibula, femur to go for the popliteus and the PFL, and go near the fibula for the biceps and the FCL, fibula collateral ligament. Now, if you have an anteromedial bone bruising, it's very classical of a posterolateral corner injury, and always look for that also. Now we have got these injuries, which are, you can see it's a hyperextension injury here. You can see a PCL, and you can see a meniscotibial deep MCL avulsion. This is a posteromedial corner injury. So this particular injury, meniscotibial deep MCL avulsion, is called a reverse stegon fracture. So we have got stegon fracture and reverse stegon fracture. So this is a classical reverse stegon fracture. The X-ray also shows the reverse stegon fracture. And here you can got a complete superficial medial collateral ligament injury. You can see that fibers are very wavy, and deep meniscofemoral tear is there, but the meniscotibial is intact. You can see the meniscotibial is intact. So posteromedial corner injuries are very, very important, and you have seen that. Now here you can see this is a PCL tear is there. There's a PCL tear. You can see a radial tear at the junction of the posterior horn of the meniscus and the posterior root. And then you have got the tear of the posterior oblique ligament. So this injury should never be missed. And you can here once again see the MCL and the POL tear. Now here you have got a complete avulsion of the distal superficial MCL. The superficial MCL is retracted from the tibial attachment, and it has gone anterior to the pes anserinus. You can see a Steiner lesion. So, the complete the meniscofemoral and with intact meniscotibial deep ligament also. So, and the ACL also is injured. So these are all posteromedial corner injuries. Now we come to the KD4, which is the both collateral ligaments are injured with other structures. Here you can see a ACL, and you can see in this patient the MCL is injured as and the LCL both are injured. You can see the lateral injuries and the medial injuries from the femoral side. Now here you see a dislocated knee, and you can see very clearly that both the ligaments are torn and the meniscus is stood. Now what is KD5? It's a ligament injury with periarticular fractures. Now here you can see a vertical lateral tibial fracture. Now this is a Segon's fracture, which clearly indicates a ALL injury, and you can see that along with that you have got the arcuate injury. Now here in this case you have got very clearly the arcuate sign, which is very clearly shown, sir. Arcuate ligament avulsion. Now, in this case, you can see both the arcuate sign and the Segon's fracture. You can see the posterolateral corner injury there, and you can see the ACL injury inside, and you can see the Segon's fracture here. Both arrows are seen. This is the blue arrow for the arcuate sign, and this is the Segon's fracture. Now here, this is a triple injury where you can see, you can see an ACL avulsion drawn with the black arrow. You got a Segon's fracture and the arcuate sign. So this is a triple injury. You can see the ACL avulsion in the MRI very clearly. Now there are conditions where you get ACL injuries along with vertical medial meniscus tear, and you can also see full thickness femoral cartilage avulsion. So these are the associated injuries which can happen with multiligamentous injuries. You can see a femoral cartilage avulsion here, a vertical medial meniscus tear here. So be on the lookout for other injuries also. Now, to close my session, this is a peripheral meniscal tear ramp lesion here. And this ramp lesion is very, very important. You know that it can happen with ACL injuries. But recently, there was a paper in the Journal of Arthroscopy and Related Surgery in 22, where they said over 1/3 of patients with multi-ligament knee injuries and an intact anterior cruciate ligament, intact ACL, demonstrate medial meniscus ramp lesions. And in 68% of these patients, they have got a posteromedial tibial plateau bruise. So when you have a posteromedial tibial plateau bruise with an intact ACL, always look for a ramp lesion. So these are all the new ventures in multi-ligament injuries. To conclude, the anatomy and pathoanatomy knowledge of both is essential to understand what you are seeing, and always recognize missable lesions, because that is how you save your day and save your patient also. And please have an unprejudiced analysis. Don't think that only some patterns occur for every patient. Patterns differ according to the mode of injury and the direction of the force. These are my references. Thank you very much.
Any questions from the audience? Any questions to Murali?
May I ask you a question, Dr. Murali? Which sequence of MRI would you suggest the youngsters to look at? Because there are a lot of sequences, the PDFS, the T1, T2. So which tells us about the ligaments and the fracture?
The coronal T2 sequences and the oblique T2 SAG and the fat suppression sequences, and if possible, if you have a good MRI machine, the 2D proton sequences also. These sequences very clearly show the actual injuries, their pattern, and the combinations also.
The 2D proton, is it for the bones more?
No, 2D proton is basically for all the posterior ligaments. Yeah, especially
Okay.
I showed you that the posterior fibula PFL tear. No, the PFL tear was a classical 2D proton sequence.
A quick question, Murali. It was a fantastic presentation, and like a lot of things actually I saw for the first time on an MRI. Anyway, so my question is, the images that you showed were like was with great immense clarity. You know, the images that you showed us.
Yes.
Now, are those MRIs like a 3 Tesla, or is it a regular 1.5 Tesla with a knee coil?
Yeah, like you said, for all the references that I had, except for one reference, all the way from 3 Tesla MRIs, and they were with all these proton sequences, and they got special sequences like fat suppression images and everything. That is, specifically to speak, that is a paper from Todupuzha. And it was a good paper in which they presented about 108 posterolateral corner injuries, in which they were telling about their findings. And that paper was interesting for me, from which I think they have taken only 1.5 Tesla.
Murali, there is a question in the chat box. What about PD images? Dr. Scott has put in.
What about?
PD images.
Proton density.
Yeah. Proton density. So 2D proton images and proton density images are both good for understanding early bone contusions and all these subtle injuries like partial tears and segmental tears of ligaments. They are good, but I do not have any specific experience with seeing only PD images.
Now, Murali, can I ask you a question?
Yeah.
So, after before we go to the next talk, once a patient comes to you an acute injury to your practice into your OPD, after imaging, how will you go about with this patient? Will you go and repair all the ligaments which is which you see in your MRI, or will you do, after giving anesthesia, will you look for further, to clear your findings, clinical findings, again to confirm your clinical findings, then go for a repair? Do you like to go for a single stage or a two-stage repair?
If I have a patient who has got a multi-ligamentous injury, I first counsel the patient to say that there is an injury inside the knee, an injury on the corner of the knee. And it's always better to have a two-stage operation at your informed consent level. And where I work, if I take the patient twice to the theater, once for understanding the anesthetic ligamentous stability, and second for operation, he will run away. So what I will do is, wherever possible, I will try to, if it's an acute injury, try to solve it in one go. If it's a chronic injury, I may go for a two-stage reconstruction also.
So what I meant is that all my cases where I get a multi-ligament injury, even though I get all the images, I go through the images. After giving anesthesia, I examine myself, all these patients,
Definitely.
and see what all injuries are there. Then only I decide on which ligament to repair and what to go. Because
Shall I put in
feel
one word?
that, yeah.
Shall I put in one word? I find that
Please,
many often than not, this MRI reports go against the actual findings, and I don't know about the impression by all. Unless you have got a very good radiologist, I find that in multi-ligament injuries, not all the ligaments are documented, and some ligaments which are intact are also documented. So, as you said, it's always good to go about by ourselves and tell the patient that the MRI is only a pathfinder and not the final Bible for the actual injury. And it is we who have to go inside and see which there are several mislesions which are possible to be missed by the MRI. We always say that counseling to the patient, and then only we go about it.
Hey,
Yeah,
Murali,
well said, Murali. That's
what
we follow.
Yes, sir.
Okay, sorry. One quick question. I mean, this MRI that you take for multiligamentous injury, in an acute stage, when the patient comes with a lot of hemarthrosis, fluid, and soft tissue edema, do you get reasonably good images and the differentiation between the different tissues, on the MRI in an acute stage when you do MRI? Do
The
you
single
really
word
get a
answer
good?
is yes, sir. I understand. The single word answer is no, sir. That is why in the presentation I very clearly told that don't take an acute MRI, because acute MRIs are always misleading. Some things are not seen. Some things are seen more than they need to be seen. Subacute phase, said after the edema settles, that is the correct time to take an MRI, because then you get the subacute injuries, and there you get the pathoanatomy very more delineated, well more delineated. Yes, sir.
But again, you are justified in doing an MRI in the acute stage, and then I suppose you could like repeat the MRI again after a couple of days when the angry looking knee is like sort of subside, the swelling is subsided and all that. For example, like if you don't do an MRI in the acute stage, you might miss certain things which you might have to immediately address, like irreducible meniscus and things like that.
Yeah.
So I mean, is it justified to take like 2 MRIs after I mean,
as far as radiation is concerned, it's okay, sir. But when you look at a patient where you have to do things one thing at a time, maybe a stress X-ray and evaluation, clinical evaluation will tell me some things. Definitely physical examination, and with that, I can counsel the patient that after 2 weeks when I do, it will be good, because in multi-ligament injuries, I expect more lax instability than not. So in those kinds of cases where you look for a locked knee, maybe you can definitely take repeat MRI. One question I have for the elite faculty is this particular low velocity dislocations in obese patients. Have you come across, and what is your experience? Hello?
I think
Am
the
I
next
audible?
I mean,
next couple of. Hmm.
are you?
What is the question?
No,
My question was this low velocity dislocations in the obese. Uh, is that a thing? Have you come across that? And what is the experience with this kind of a injury for all?
All these obese patient with low velocity, like people, falling, slip and fall, obese woman falling in the bathroom, in the kitchen. This kind of
Yeah.
injuries can come in. So you have to be really careful. Most of the multi-ligament injuries are these kind of patients or a bike accident. They are bike falling in. You hardly get where sports injuries with multi-ligament. Most are RTA where you have the bike falling onto the leg and having this. So obese people you have to be really careful because these especially these ladies the tendons are very small compared to the magnitude of weight they have to hold. So I feel all these patients require acute repair. Preferably whenever the swelling and the edema comes down, I from the injury and do it because the healing, the natural healing of the repair is better when you do in the acute phase, and you have to augment it also whenever you do like you are doing all to, like I think posterolateral corner again is coming, so he'll talk about more, and also MCL. It not only repairing it when you are doing an obese low velocity injury, multi-ligament injury. So one more thing I want to stress is that all these multi-ligament injuries, you have to, when you are having really not the multi-ligament KD1 or 2, when it comes to KD3 or KD4 or KD5, you should always suspect vascular injury. So you have to do a CT angiogram preoperatively. Otherwise, you can land up in a problem. Not only MRI, a CT angio is also required because your surgery is prolonged. If you are in a tourniquet, if you have missed your vascular, patient must be having a spasm of your popliteal only. They must be having some collaterals. It may be running on that collateral. So always in multi-ligament injuries, when you think, you have your cruciate and one of the ligaments gone, you suspect it is a, bad injury here, then especially posteromedial corner is also gone. You should think about taking a CT angio.
Fine.
Any comments on that, Murali? So imaging is not only the imaging of the knee, you have to image your popliteal vessels also.
well, in the acute stage, I suppose you may not. If you think it's a cold, pulseless limb, I don't think you'll have time for going and doing a CT angio. You'd rather reduce the knee and then check if the vascularity is. You can do a Doppler study, or you can do a what you call that index
Yes, sir.
brachial, and
CT and
yeah,
I,
and see if the
I
vascularity
differ
is
to it, sir,
returning.
because all CT angio hardly takes half an hour. Without CT angio, if there is an injury, the vascular surgeon will never intervene. So you have to have a CT angio.
Yeah,
There is
that is
no doubt.
true.
If you suspect,
That is true. If the vascular
that
surgeon
has to
has,
be done.
yeah, the vascular surgeon, if he has to intervene, he would need a CT.
Intervene. So
But what I'm saying is, what I'm saying is, like, if the
yes, sir.
knee is a dislocated knee and you don't have a pulse, there's
You
no,
reduce it. That's
yeah,
all.
we can reduce it much before you do a CT angio, or and then wait and
Sir, that is very obvious. Any dislocation has to be reduced. Yeah. Has to be reduced, but you have to do a CT angio in the imaging part. Before doing your MRI, if you have multiligament, you should do a CT angio before you go in. Because you once you start doing a surgery under 20K, you might land up in trouble. So you have to document it for your medical legal issues and to for your vascular, colleague to come in if it is required.
It's true, I
Yeah.
guess, even for a chronic multiligamentous injury knee, when it comes to you for treatment, like
Yeah.
after several months, it's always better to again do the CT angio and vascular before
In
you
chronic,
plan anything.
Yeah.
Even if you get a distal pulse, or even if the vascularity looks okay, if it is a multiligamentous injury coming to you after several months for a reconstructive procedure, always go in and check do the CT angio or whatever to check the vascularity before you touch the patient, before you operate on the patient. I suppose.
Those are wonderful points from the experts. Shall we go on to the next talk, John? Dr. Rajanish
Yeah,
is
please.
impatient. Yeah.
Yeah. He's always.
Yeah. We'll have the discussions towards the end. More things will evolve.
Yeah, good evening. So my topic is on posterolateral corner injuries of the knee. So posterolateral corner comes about, means anatomically 3 layers are there: the superficial layer, the central layer, and the deepest layer. Superficial layer consists of the IT band and the biceps femoris. Central layer consists of the lateral patellar retinaculum. And the deepest layer, the lateral capsule, FCL, popliteus, and the popliteofibular ligament. Coming to stabilizes FCL, popliteus tendon, and the popliteofibular ligament. This is the popliteus tendon, the popliteofibular ligament, the FCL. That mainly consists the posterolateral complex. Coming to FCL, it's a primary varus stabilizer providing restraint to the tibial external rotation up to 30 degree of knee flexion. Secondary stabilizer to internal rotation. The femoral attachment is a small bony depression, slightly proximal and posterior to the lateral, slightly. The FCL is attached slightly proximal and posterior to the lateral epicondyle, causes distally to insert to the fibular head. It is around 8.2 millimeters posterior to the anterior margin of the fibular head and 28.4 mm distal to the tip of the fibular styloid. This is a popliteus tendon, and the femoral insertion. The popliteus tendon, the femoral insertion is 18.5 mm anterior to the fibular collateral ligament attachment with the knee in 70 degrees of flexion and in the anterior half of the popliteus. This is the FCL and this is the popliteus tendon where is inserted. Causes distally and posteromedially deep to the FCL. Causes medially and posteromedially deep to the FCL. Stabilizers for external rotation in the knee. Secondary stabilizer to varus stress. Minor contribution to anteroposterior tibial translation, specifically in full extension or deficiency of either cruciate ligaments. Coming to the popliteofibular ligament. Popliteofibular ligament, the originates at the musculotendinous junction of the popliteus. Two division, it has got an anterior division and a posterior division. This is a popliteus tendon, this is a popliteofibular ligament. It has an anterior portion and a posterior portion, embraces the popliteus tendon and inserts distally on the posteromedial aspect of the fibular head. Other static stabilizers are the thickening of the lateral capsule with the meniscofemoral and the meniscotibial attachment. The fabulofibular ligament, the arcuate ligament. This is the arcuate ligament. The dynamic stabilizers are the lateral head of the gastrocnemius, ITB, and the biceps femoris. Coming to a few words of the popliteomeniscus fascicles, there are 3 numbers. This is the popliteomeniscal fascicles. There are 3 in numbers: the antero-inferior, the postero-inferior, postero-superior, form the boundaries of the popliteus hiatus through which the popliteus tendon connects the lateral meniscus and the posterolateral complex in the popliteal hiatus. How the injuries are caused and how much it is. Around 5 to 9% of all knee injuries is a posterolateral complex injury, and 16% of all ligamentous knee injuries, usually associated with ACL and PCL injuries. Mechanism of this injury is like this: the direct or indirect blow on the non-contact hyperextension injury can also cause this, whereas non-contact injury is the other cause. Up to 70% of the PCL injuries are missed in acute setting. About 70%. How can you diagnose it? By the history, physical examination and imaging. Physical examination, external rotation recovery test, dial test, varus stress test, heel height test. Pertinent imaging, what you require is X-ray, plane and varus stress X-rays. This was earlier discussed by varus stress test at 20 degree of flexion. If ACL injury, there will be around 2. So you need the X-ray of the also have a bilateral long AP, long X-ray. Repair in this MRI figure. And coming to classification, posterolateral classification mainly by Hoogsten and in Hoogsten, what is so great? Hello.
Yeah, you can go ahead.
Yeah, we can.
Posterolateral corner classification mainly by Hoogsten, and finally Hoogsten he graded 1, 2, 3 depending upon the amount of aperture and the rotation, external rotation deformity, 0 to 5, 5 to 10, and more than 10 to. And finally, grade 1, grade 2, grade A, B, C, depending on the increase in the external rotation, increasing tibial external rotation plus mild to moderate instability in varus stress, increase in the tibial external rotation plus severe instability in the varus stress. So, if what happens if it gets untreated, there will be rotation instability, and if you are reconstructing the ligament, there will be a failure of the ACL graft or the PCL graft if the PLC ligament PLC complex is missed. So how to treat it? Treatment may be non-operative in grade 1 or grade 2 injury. In operative, you can have operative grade 3 injuries. You go for operative treatment in grade 3 injuries, and grade 2 injuries, other structures, if it is injured, you can go for an operative treatment. How important it means, how efficient is a direct PLC injury? Usually the PLC injury direct repair usually fails, usually not feasible due to the tissue disruption if avals can be reattached at the anatomical location, but not at the mid substance and on. So recommendation in acute grade 3 injury, surgery within 3 weeks, that can be repair plus minus augmentation. Why? Because the lateral side of the knee is already unstable because it is convex on convex, while the medial side it is convex on concave. So high failure rate if you go for a repair. More than 3 weeks, better to go for a reconstruction. These are the studies which proved that the repair usually has bad results. 37% failure rate in repair group versus 9% in the reconstruction group. There's a great difference of 28%. Levy et al. Has told that in 40% failure rate was reported in repair group was 6% in the reconstruction group. So always better to reconstruct, or if you are going for a repair, better to augment it. If you are planning to have a treatment, always you have to have a FLS view, because the malalignment with chronic PLC injury will again lead to a failure. So significant malalignment, there will be a dynamic varus gate thrust. Correction of malalignment prior to surgical reconstruction is necessary. That is by doing a HTU. 38% show resolution of symptoms just with proximal tibial alignment correction. Whether 2-stage or 1-stage, better to go for a 2-stage. First, in a chronic PLC injury, go for an alignment correction. That is by HTO. Reassess later. Most of the time, you won't have to have a PLC reconstruction. That is after correction of the malalignment in a chronic PLC injury. What are the techniques for PLC reconstruction? They usually means the 3 known techniques are the Larsen. There's a modified Larsen also. There's a R0 technique and the Laprade technique. In Larsen and R0, they are fibular-based technique. Fibular-based technique. They reconstruct both the FCL and FPL, the FPL ligaments. You can see this. And the FCL. It is reconstructed in Larsen. Only one tunnel is made in the femur. Here, anteroposterior tunnel in the fibula, graft is looped in the tunnel, and both ends are fixed at the lateral femoral condyle. In Lepran, this is a very interesting technique. You need to really have good technique, and you have to be well versed if you are doing a Leprat method. It's an anatomical reconstruction, almost, not fully. There's popliteus tendon and the popliteofibular. This is the popliteus and this is the popliteofibular ligament. Though this part is not anatomical, the rest are anatomical. It's a combined tibia and fibular based technique. No significant difference between the intact means non-injured knee and the reconstructed knee with respect to varus translation and external rotation at the flexion angle. Means this is a more anatomical repair, and it gives its good results. How the steps? You have to have a neurolysis of the common peroneal nerve, then typically located neurolysis of the common peroneal, typically located the posteromedial aspect to the biceps femoris. It should be dissected proximally first, identify the nerve, and then come distally. Distally, peroneus longus facial incise to prevent the post-operative irritation of the common peroneal nerve. You have to excise the fascia and make sure the common peroneal nerve is free, so to avoid the post-operative time irritation. Then you have to have the posterolateral dissection. That's the interval between the lateral gastrocnemius. That's the lateral gastrocnemius and the soleus. You go posteromedial aspect of the fibula, styloid, and the popliteus. This part is exposed, and there's a horizontal incision over the distal portion of the biceps femoris tendon. Underlying the biceps, bursa is incised to locate the mid portion of the FCL. If there is any FCL remnant there, it is very easy to reconstruct it anatomically, tagged and stitched. Then you have to go for identification of the FCL remnant and the fibular attachment, drilling the fibular head tunnel and placement of sutures, and the drilling is anterolateral to posteromedial. The drilling should be anterolateral to the posteromedial. Then go for the drilling of the tibial tunnel and placement of the passing suture. There's a flat spot at the anterolateral tibia. There's a flat spot in the anterolateral tibia anteriorly, medial to the Gerdy's tubercle, and the drilling should be directed to the tibial popliteus sulcus, that is posteriorly 1 centimeter proximal and 1 centimeter medial to the fibular tunnel. Then identification of the femoral insertion of FCL and the popliteus tendon. There will be a groove, sulcus will be there, popliteus sulcus. Then drilling the femoral tunnels and placement of the sutures. Proximal fixation and distal passage of the graft should be there. Distal fixation of the graft, fibular head first, then the tibia, then FCL graft fixed with the knee in 20 degree of flexion, neutral rotation, and gentle valgus should be there. Gentle valgus first. The popliteofibular ligament and the popliteus tendon in need 60 degree of flexion and neutral rotation. So then comes to the R0 technique. It's a fibular head based, no tibia is involved. But the difference between the Larsen and the R0 technique is in drilling the fibular tunnel. Here, the free soft tissue graft recreating the FCL and the popliteus tendon. FCL and the popliteus tendon on the femur. Dual femoral socket technique. In Larsen, it is only a single socket. This reconstruction technique predictably restored the varus and external rotation in stability. Most of the people are nowadays following the R0 technique. So, what is the difference between R0 and Larsen? In R0, it is an anterolateral to posteromedial tunnel. Anterolateral to the posteromedial tunnel, and in Larsen, it was an anterior to posterior tunnel. This is a more anatomical trajectory, decreases the risk of common peroneal nerve injury, as the aiming is like that. Okay. Then better reproduction of the FPL, PFL anatomy, posterofibular ligament anatomy. Well, how to avoid the convergence? You have to drill this tunnel. There will be a socket here, the popliteus socket. The fibular collateral ligament is posterior and the popliteus tendon is anterior. So you have to drill two tunnels at around 1 centimeter, 1.8 centimeters apart, and that should be directed around 35 degree superiorly. So you can avoid the convergence, and it actually usually you can divide that ACL reconstruction tunnel also. So what is the algorithm? This is the same. If there is a PLC injury, if there is a malalignment, correct the malalignment by valgus osteotomy. Then you have to consider about the PLC surgery. If there is no malalignment, then look for the central pivot injury. If there is a central pivot injury, you have to go for a multi-ligament reconstruction. The order should be the central pivot PCL, the ACL, and the PLC. Better to do it in single stage. Some people like to do in two stage. So if there is no central pivot injury, then go for this thing. If it's a grade 3 or grade 2, whatever it is. If it's a grade 3 injury, PLC grade 3 injury, then go for surgery. It is in acute cases, if it is an avulsion, you can go for repair. If no avulsion, it is better to repair and augment. If it's a grade 3 injury, then you can go for a reconstruction based on Finale classification. If it's an isolated popliteofibular ligament, this A, you can go for a isolated popliteofibular reconstruction. If it is B, go for R0, and if it's a C type, you can go for fibular head based reconstruction. And going for rehab protocol, usually it takes around 9 months, 6 to 9 months. Initially around 6 weeks non-weight bearing. Then you can have a range of movement exercise, passive range of movement 0 to 90 during the first 2 weeks, and progressive to full range of movement as tolerate. But for 6 weeks, better to go for a non-weight bearing. In between, you can have the range of movement. At 6 weeks, begin stationary cycle and you can wean off the crutches. Once a full weight bearing is there, you can go for a closed chain muscle strengthening exercise. First, develop endurance before progressing to strengthening. Then, hamstring strengthening is limited because there will be a posterior slag if you go hard on hamstring strengthening to avoid stressing the reconstruction until minimum of 4 months. Then return to sports when normal strength, stability, and knee range of movement is comparable with the chondra usually attached around 6 to 9 months. This is one of my cases. It was ACL reconstructed knee with the ST gracilis. Initial repair was done for bony avulsion of the fibular head with an anchor. Okay, but it failed. Now there was an ACL injury, PLC injury, and posterolateral complex. There's an ACL injury, posterolateral complex injury, and a PCL partial injury. The graft was for ACL. This ACL graft, ipsilateral peroneus graft was triple, size was 9. PCL, it's an augmentation mainly the PL bundle. The opposite side, peroneus longus graft was there, and it was doubled only. Size was 8 mm. For PLC reconstruction, it was a Lapra technique, which I usually use, which I like also. Popliteal, where you can reconstruct the popliteofibula, and the FCL reconstruction using the contralateral. The graft used was a contralateral semitendinosus. The graft size was 9 and length was 26 centimeter. Actually, this 26 centimeter was 12 by 12 for fibular collateral ligament reconstruction and 614 for popliteofibular ligament plus popliteus tendon. So this was a final X-ray. The tunnels were made. This is how the tunnels is made. This is from the anteroposterior view. This is a posterior view of the tibia. You can see the tunnel coming from anterior to posterior. This is a fibular collateral ligament that goes and comes like this. This is the popliteus tendon. So this is the popliteus tendon. This is the part which goes, then comes and go for the fibular collateral ligament. So there is two bioscrew. One is bioscrew is here and one screw is here. Actually, what I used to do, I don't take two tunnels. I take a 9 mm screw on either side of the screw. I pass the graft for the fibular collateral as well as the popliteus tendon. Thank you.
Any questions? Any questions from the delegates? It's a very, common injury and you have to identify it first. That is the most important thing. Otherwise, you can land up in problem. Any questions from the floor? There is no question. Let me ask Rajanish. When
Yes,
will
sir.
you plan? When will you plan for modified Larsen, and when will you do leopard leopard in your practice, or you go for leopard for all cases, or
Nowadays, I
modified?
prefer going for leopard for major, means if it's a type 3 injury or grade 3 injuries and all. Most of the time I do leopard only or Larsen. I don't do R0.
No, I'm telling you, what is your indication for doing a Larsen, and what is your indication for doing a leopard, or you do all Larsen or all leopard? When will you do Larsen? When will you do leopard in your practice? I have
If it's
my
a,
own thing. That's it.
hello, can you hear me? Hello.
Yeah, yeah. Well and good.
Yeah.
Well and good.
If it's a external rotation injury, if it goes for external rotation and if there is a more opening under anesthesia, say more than 5 degree of external rotation when compared to the opposite knee, and if the opening is less than 5 mm. Hello. In such cases, I go for the Larsen. If it is more than that, I prefer to do a leopard.
Okay. For me, any patient where you do repair that is less than 3 weeks, you augment it with a Larsen. And any patient coming after 3 weeks where you are reconstructing, we have to do a leopard.
So why is it like that, sir?
Then acute, because you have to, Larsen, modified Larsen, you require something to augment your repair. So it's an easier procedure, and you are going for a bigger surgery. You are doing all the ligaments together, and you are repairing it also. You require an additional support only. So Larsen is enough. But in a chronic state where you don't have anything to repair, you have to have all your, rotatory stabilities coming in. There, doing a Larsen will not, a Larsen will not work. You have to have a leopard when it comes to more than after 3 weeks. So if you can repair, augmentation is only required, then Larsen is fine. If it is after 3 weeks, that's a chronic injury, leopard is always a must. Any take others?
The way I look at it is slightly different. The way I look, am I audible? Yeah. Am I audible?
Yes, you are.
Okay. See, if you look at the whole complexity of this injury of posterolateral corner, all of them are not the same. I tend to stick to modified Larsen most of the time, what I do now. Only for those patients who have a significant varus instability, but not a case where the entire lateral tibial falls or rotates backwards and falls backwards. Like you have a significant dial test or a reverse pivot shift, where the lateral tibial condyle actually subluxate, rotates externally and falls backwards, where there is a significant rotary component to it. We have to always think of reconstructing the popliteus component of this PLC injury. In such cases, it's always, I think, leopard serves our purpose better. But let's say like you have a patient who has slight varus instability, but not a very significant dial test. In such cases, I guess you could go in for your Larson's or a modified Larson's or whatever. That's how I approach this problem, because all the posterolateral complex injuries are not the same. The severity of the instability varies from patient to patient. But if you have the component of the tibia rotating externally and the condyle falling backwards, like in a very severe posterolateral corner, I think Larson or a modified Larson or the other technique what Rajanish was mentioning, I think it's called Asiro, I don't know the correct pronunciation. Okay, you could think of those procedures, but otherwise you have to go for a Laprade, I guess. That's how I look at it.
I'd like to put in one word.
Chronic case.
Sorry?
It is all different now when you come into an acute injury and a chronic injury. So you're talking about a chronic injury or an acute injury. In acute injury, you will be able to repair most of your stuff if you're coming earlier. Then you might be able to repair. So if you are coming early, within 3 weeks. So you require only an augmentation.
And there is also the thought process that a tibial-based posterolateral corner reconstruction should be thought about when the varus opening is at 0, 30, and 90. Otherwise, a fibula-based reconstruction also like a modified Larsen or Asiro would do. In addition to the chronicity, as Dr. John said.
Yeah, it essentially boils down to the same point, like 0, 30, 60, 90. When you have a lateral opening, essentially it means the tibia is like falling away when the knee is, yeah.
That's when a Laprade is really indicated.
Yeah. Rajanish, I have a question for you. You mentioned like tightening, while doing Laprade, that you would tighten it at 20 degrees, you would tighten the fibula collateral, and at 60 degrees, the popliteus. Is that right? Is that what you said?
So that's how the Laprade has already told.
So which
original
end?
Laprade.
So which end of the graph do you actually fix first?
Fix the fibular side, but the tightening in the femoral side is at different angles, 20 and 60 degrees.
Do you put a screw in the fibula?
So I don't put. I usually suture it because our fibula is not that big, and it's very difficult to get a foramen.
So that means we have only no fibula side. We have only tibial side
tibia,
and femoral
tibia
side.
You have to fix first. First tibia means the size of the graft should be for 12 centimeters for the 12 centimeter for the FCL and 14 centimeters for the popliteus tendon with the popliteal fibular ligament. So while passing, first you put the screw in the tibia. Anteriorly, you can put the screw.
Anterior. Okay. Got it. You fix the tibia, you don't put a screw in the fibula head. And
fibular head, you suture it so that it doesn't move and all. When you go to the femoral side.
Absolutely clear. Got it. Thank you. Since you don't have a screw in the fibula thing, like I was a bit confused about it. Yeah. Thank you.
Thank you.
Shall we go on to the next talk, John?
Please, next talk. Pradeep.
Yeah, I am ready, and Rajanish has to take away his screen now.
Yeah, we got a national faculty, Dr. Pradeep, joining us today to talk on his vast experience from Bangalore.
I am from Koyanjeri, basically. No, Muralikrishna's place has got 2 people talking. That's it. And thanks, Sujit, for giving and calling me this talk. And Schiller, sir, always wonderful to talk in front of you now. And let's see how much you catch me. So there are many different things which I will be talking, compared to Dr. Rajanish, what he has talked. And there will be some controversies that may come up if you hear it. So Dr. John was telling that he had presented in 2017. So in fact, after hearing the talk, I had taken his whole PowerPoint, and there are some slides which whatever he has written, I have written. Okay. So especially the theory part of it. So it is 2017 theory. So this is still valid. What is a multi-ligamentous knee injury? Okay. So it's basically a complete cruciate ligament injury with a collateral ligament injury, or any other cruciates is also gone. So that's a multi-ligament. And now the classification is, we have discussed on this. The commonest thing that we find is an ACL plus collateral. Now, when you have an ACL with a medial collateral, that is the commonest finding that is the multi-ligament that we see. Take home message for treating this is, don't take the same sided hamstrings for this case. If you are a hamstring based surgeon, take the opposite side, or you can take a quadriceps tendon or something else to do that. And when you have with an MCL, classify them into whether they are type 3A or type 3B. Type 3A means incomplete extension, you don't get an opening, but when you take it at 20 degree, it opens out. Such cases, ACL reconstruction alone without touching the hamstring tendon will be good. But if you have a type 3B where it is opens in complete extension also, that also needs to be handled in same time. Now, 2 is ACL and PCL. It's quite common injury where the collaterals are intact. Type 3, medial, ACL, PCL, and medial collateral. So, as Dr. Rajanish has already talked about type 3, that is the lateral side one. So, I'll be more focusing and discussing on based on a medial side injury. So, best way to learn about how to handle a multi-ligament would be to take on a case presentations as such. So what we should have, when you see a patient, you should evaluate. And this evaluation is very, very significant. Have a plan and have an expectation set to the patient and speak about it, about the long-termness of it. Now, when you look at a patient itself, you have to look at whether it is a high velocity or a low velocity injury. Some of them are bony avulsions and some of them are ligament failures primarily. Vessel status and nerve status. Vessel status, there was a discussion, is very important. This once we had a multi-ligamentous injury patient, pulse was palpable. We posted him with a knee brace and put him inside the hospital. The very next morning, the night pulse was there, morning pulse was not there. We had to go directly for an external fixator then because no, sometimes there's an endothelial injury and the vessels may go. So we have to be very careful that how you immobilize them. A little flexion given would be a better one. Nerve status has to be assessed. And when to operate becomes a big question. Waiting for 2 weeks, 3 weeks, 6 weeks. And then what are the graft choices? Do we plan all of them together? And once you do this surgery, equally important to get a good result would be plan your rehab properly. You should have access to cryotherapy, braces, muscle stimulator, and watch them carefully, have guidelines and landmark to achieve in each phase of the rehabilitation. So that's how we will be looking at a case. So when you see a patient itself, you have to start thinking in the way of what results are you expecting in this case after a certain time. So I'll just show this. This is a case-based discussion. This is a young man who got a road traffic accident. And in this road traffic accident, he had multi-ligamentous injury. Now, if you look at the injury, he has injury to all the 4 corners, but the fibular collateral ligament is intact. The MCL was completely torn off with ACL and PCL. This is the other view where we can see that the ACL and PCL is also completely disrupted off. The fibular collateral is intact and the popliteus tendon is also intact in this case. And the third image is axial, looking at the patellar part of it, and the medial side disruption becomes very obvious in this. And now when we go in and see, this is what is the picture, the condyle is seen medially. The whole bone on the proximal tibia is exposed off. The deep collateral ligament and the superficial collateral ligament, both of them is multi-layeredly damaged. The tendons are intact and tendon can be felt. The whole area is exposed. So now in this case, if I do a primary arthroscopy and go ahead, so we took the patient up on the 7th or 8th day of the injury and we repaired off these deeper structures. So the place where the previous one, if you see, this is the menisci. The menisci and the things has to be attached back to the tibia. Here, the collaterals have to be with suture anchors sutured here, and then you try doing the other part of the surgery. Now, here we used a Danish technique. We did a open, that is close stripping of the semitendinosus, and then we made a graft of the appropriate size of what came from that, and did a augmented repair. That is, we did a repair of the tissues, whichever was possible to repair. And after that, we augmented with using a Danish technique, which is basically a single tunnel on the femoral side. And then for the POL, we use an anchor there and make an additional point and then bring it down and suture again. So that's how the fibula part is done. So the PCL was done on the same sitting. The ACL was also done on the same sitting, and additional anchor was placed at the deep collateral where it should be. So all the ligaments in a single stage done and finished. Now, 9 months post surgery, after his rehabilitation is completed, this is how his standing time, extension and flexion. The extension was achieved complete, and getting this much amount of flexion, almost like after that there was a lot of, so on the 6th month he complained of a lot of crepitus in his knee. We had to give some visco supplement to it, so that went off with that, and the extension also was completely achieved. He could raise his heel of the thing. Now this is another case where this is a multi-ligament injury. So we are talking about obese ladies here and treating. Here is a very low velocity injury, just had a slip on a treadmill. Okay. There is a very small avulsion seen here. There is an ACL and a PCL. All the things have got avulsed off with small tendons. And the patient comes directly on the 4th or 5th day from a little faraway place. And we see that all the ligaments are avulsed. So this is a good scenario, no, where we can just go ahead and repair and pull them out. So I did an open PCL here. I fixed it. I did the avulsion part was fixed with anchors. An additional stability for the popliteofibular was provided with another cancellous screw. The tibia was fixed back, pulled down with suturing on the bony avulsion, and the patient was treated. So where some controversies, so repair versus reconstruction. So in anatomic reconstruction of cruciate ligament, so whenever we are doing, so it should be anatomical technique. So better is always a double bundle in a PCL, but the problem is then when you are doing a multi-ligament, so if I am doing a PCL isolated, I always do a double, but when it is a case where it is coming as multi and we don't have access to, so we tend to do a single bundle here. And always high reoperation rate has been reported in a posterolateral injuries treated with repair. So posterolateral injuries, except for bony avulsions, it is better to always reconstruct it based on. So as Schiller sir was speaking, variations are very important. If we go in arthroscopically and we find that the popliteus is intact, then such cases Larsen and all should be fine. But if it is a completely opening out, I think I largely go towards doing only Laprade. And the tensioning sequence. So first PCL, then there is no controversy in that you do that. But if you have a posterolateral complex, it is very important not to fix the ACL first, but to do in a PLC deficient. If you do ACL first, it increases the external rotation of tibia. So it is very important not to do and to fix the PLC prior to the ACL to avoid the tibial external rotation. And we have to be cautious of it, that the tensioning sequence is right. And rehabilitation, very important. Surgery is over. You do a perfect surgery. We give antibiotics for 1 day extra. Usually 3 doses antibiotic, we stop it. But in these cases, maybe you give it for 3 days. Pain control, cryotherapy, and elevation, range of motion establishment and mobilization. And once the rehabilitation at each stage, you should know how the patient should, what they should gain. Extension should be gained by 3 to 4 weeks. If that does not come, then you are in tough state. use of appropriate brace. For example, don't shy away from telling patient that you have a PCL brace available. And if you have, they can afford it, they should use a PCL brace because it will prevent the sagging. And when you have done all the things together, the results tends to be good and you can mobilize, in fact, faster. So I think my talk is done. So I have made it in that fashion. So I have put it in a case where one case based, you have a medial condyle thing. We have every case is a learning point in a multi-ligament. So some cases this vessel goes, then the results are not going to be as good. You have to put an external fixator, wait for 3-4 weeks and do. Some patient may come to you after a vascular repair and 3 months later they come. And there you'll have to talk to them a lot about how to how long can we use the tourniquet, looking into the angiogram very carefully, talking to your vascular surgeon once. So all those becomes, and even trying to do the surgery from beginning without a tourniquet with just pump, that also becomes one of the options in such cases. So thank you.
John is still around?
Yeah, Pradeep, nice talk.
Thank you for the slides also, John. Do you remember these slides?
Yeah, I remember the first slide and the second slide. Yeah, but I don't remember you taking it from me. I think you got it from.
Stole it. He stole it.
No, I took it from you. You only sent me.
Okay.
Pradeep, next time I'll be careful if you are sticking around the preview place. Be careful.
So one important thing, Pradeep has told is that when you have an MCL injury where both the sides, the superficial and the deep is gone, just repairing alone may not work. You have to augment it. So that is very important, especially, like what Murali has told, in an obese female, you have to always augment your MCL. Not only the PLC, I feel that, especially in a obese or a very active person, you have to augment your MCL also. So you have to be very cautious when you are taking your hamstrings also. So that is also very important. What is your view, Sujit and Schiller sir? Others, please contribute. How often you augment your MCLs? Because that is again a controversy. Like a lot of people in acute stage when it comes less than 3 weeks, they don't augment. They just repair it only.
Yeah, the tissue quality may not be good, isn't it? Tissue quality may not be good, and the repair may not be very strong. And instead of immobilizing for a longer period, augment it and mobilize it faster. Like the internal bracing can be done, or you can add a graft there. And the allografts are coming up now. We are getting more allografts into India. In multi-ligament scenario, I think we should be discussing about the new allografts which are coming in as well. Uronics is actively marketing the allografts, the ligaments. They said one graft costs something like 7,000-8,000 rupees. That is actually acceptable for a.
Sujit, they are charging 65,000 for the soft tissue graft.
For Achilles tendon, isn't it? But smaller grafts, I think they are giving for smaller.
No, all soft tissue grafts. For the bony thing, they are giving for 7,000. Soft tissue is 65.
Soft is expensive, yeah. But then still there is an option. As Dr. Pradeep said, the PCL braces. Again, there is one E-Life I was talked to about a few days back, which gives the PCL gives for about 16,000 rupees. The Breg and the DGO were like 50,000 rupees for a PCL brace, but it's much cheaper now in India.
Which company?
E-Life. They said 16,000 for a PCL brace. That is actually, it looked exactly like a good Breg brace. Actually, a good option.
The one which is Osur one, it is around 1.2 lakhs for Osur.
Yeah. Those international brands are bloody expensive. This is made in Taiwan, they said, which I think will add on because we are afraid to talk about a PCL brace to our patients. It's almost like 1/3 the cost of a surgery.
So another important thing is that when you have a multi-ligament injury, you have to always repair your PCL. Once a sag has developed and it has become chronic, you will not be able to correct that posterior sag, even if you do a double bundle or a triple bundle. or quarter bundle, whatever bundle you do. So you have to do it in a multi-ligament stage or PCL early. So that's very important. Those who are doing, two stage, I don't do two stage now. I do, for pretty long time, I have been doing only one stage because that has been an issue. So you have to do your PCL, within 3 weeks. That's what I feel. So, Schiller, sir, how do you take it?
Yeah, that's true. Like it is called as a chronic posterior drawer or a fixed posterior drawer that would develop if you neglect your PCL, and you may not be able to actually reduce it later at a later stage. I totally agree with you. Regarding the first question that you asked, like I always augment my repairs. I don't never do repairs alone unless even if it's even in some cases of avulsion, I'd like to rather augment all the in acute cases. But we get less number of acute cases compared to the chronic cases. But if I'm repairing, I always augment my repairs, whether it's MCL or lateral side tears or whatever. I have a question to Pradeep. See, when you do your MCL reconstructions, do you use a C-arm to mark the point on the femur where you would actually attach the femoral end of your graft for the MCL? Do you use a C-arm and a K-wire or something to mark it? Do you follow the landmarks that are described for MCL?
Sir,
Or do you for MCL, medial collateral ligament?
yeah, so MCL, I have basically in this multi-ligament setup also, or even in an acute setup. So I have got some of these Gusti players and all who have got these MCL isolated grade threes. So, but I had never, so we just expose the whole thing, look at the anatomy there. You can see the areas where it is attached. You look at the various landmarks there. So I have personally never used.
Why
Look
I
at the
asked you that
theory part of it, putting a clear and isometric and all these they talk about, but I have not used it. I just identify so in an acute setup, for example, this case, which I had just presented, the femoral side was intact. So when you pull on that fibers, you will exactly reach the deep part is a little deeper in the superficial, you exactly reach that place. So you just put your anchor in that exact place. In a chronic case, also, I always expose that region and just take the anatomy there and go there. Medial epicondyle area and then little more backwards and down of it.
No, the reason why I asked you that question is, unlike the fibula collateral ligament, where the attachment on the femur is quite clear when you dissect, it's not difficult to identify the attachment of the LCL, lateral fibula collateral ligament on the lateral side. Unlike that, the MCL has got a very wide attachment on the medial, in and around the medial epicondyle. It's not like a point of attachment. It's like almost like a crescent shaped thing in and around. So, and besides, there's a lot of soft tissues around that area and sometimes I feel totally lost, whether it's acute or even chronic, when I go there and try to uh, decide like where I should actually drill and attach the MCL on the femoral side. So what we have started doing is like how you would do in like an MPFL or whatever. But you want to find a Shortle's point similar to that.
So totally
It's
with
like
the help of
it's like a intersection between the Blumenstadts and the line drawn along the posterior cortex. That's the point of attachment for the MCL. So I always put a K wire there and do it, and I think I haven't had much problems with that. But trying to identify the attachment of MCL on the so I waste a little bit of time with the CM and all that before I start. But still, I think for MCL, unlike the fibula collateral, I think it's worth doing it. I mean, I felt it that way. I don't know about. You have anything to say about that, John? Sujit?
So
Anybody else?
exposing this area and getting the adductor tendon area and the gastrotubercle, and then accordingly planning up your collaterals just down. So this exposure, if we try to limit it, then probably we will not get the location exact. Otherwise, I think it is fairly a um, clear ligament. So once we expose, the whole area needs to be opened up. So I personally haven't had much chance of trying to put like as you say for the MPFL. So invariably we use CAM. There is no doubt. For an MCL with these kind of disruptions and all, I have not used. What is it,
Yeah,
Sujit?
I don't use CM, generally, if you look at it. Even for MPFL, I don't use CM. Because, MPFL surgeries, if you look at it, it is the one which has described maximum number of surgeries for the patellar instability. You have to come in there. Only thing you have to tension it correctly. That is the most important thing when you come to MPFL. So same thing, I go with Pradeep because once you dissect it, you can nicely see the attachment of your, even if it is a chronic case, you can see that femoral attachment. Most of the time, femoral attachment will be preserved there. You can identify your previous stem there. So we had actually few cases of femoral isolated avulsion in a multi-ligament scenario of MCL, where we did arthroscopic repair of the MCL also. So that is a very rare case. I think I remember two cases where we did arthroscopic femoral avulsion fixations. So these are all, I think, it's all philosophy. I've seen, Schiller sir doing nicely with with the Siam marking the point, everything. So it's like a robotic surgery and a non-robotic totally replacement. But I think in the end, the results are almost all the same. Even though we have robots now, I tell all the patients that, the results are the same. Same thing, if you can identify your anatomy well, which I feel which is possible. So it's okay that if you don't use CM.
And I have a small question to Pradeep.
Sir?
Shall I ask?
Yeah, go ahead.
Yeah, please.
Okay, Pradeep, since you're talking about planning for the treatment, do you have any difference in treatment plan when you go for a patient with multi-ligamentous instability and a patient who has got a normal ligament tone when you talk about these multi-ligament injuries?
No, I didn't understand what exactly is. So if you have a single ligament and multi-ligament, how do you plan?
No. Multi-ligament injuries in a patient with generalized ligament laxity and a patient with normal ligament tone otherwise.
So ligamentous laxity case should always get augmented. Always. So if they are a very lax person, so they should always get augmented, and all the things are reconstructions. So for ACL, PCL, no, even if they find this bony avulsion kind of case, which I had just told, ACL, PCL and LCL, everything is avulsed off. Such cases also, it is very important that you do more than what is required. Otherwise, they will end to stretch it out.
Fine.
Dr. Pradeep, may I ask about that same patient, the one with the avulsion, and you've done an open fixation of the PCL. There was a screw which went through the fibula into the tibia, fixing the tibia fibula. So would you remove that screw later before allowing heavier activities, or since the patient is less demand, you would leave it there?
No, I have not passed it to the third cortex. It is from fibula, the two cortex of fibula and one cortex of the tibia only. The fourth one is not fixed. And the post-immobilization phase is over. And when you start mobilization, that doesn't cause much of a problem in case it comes out. So that lady is around, I think, 3 years or more over. Very satisfied and all ligaments working, and she's gone back to her normal activities. In fact, she has lost some 20-25 kgs also. So that has benefited her overall, I think.
Because that is
just because there were too much of instability, and even after suturing all the things, there was some mobility of the fibula. So just I put a screw there.
Because that is a method which Bansha used as a fourth method of PLC, or the Bansha technique. He used to promote in all the AASKONs. I've not seen him for some time. So he uses a screw to go through the tibiofibular syndesmosis, indifferent screw, to fix the graft there and fix it onto the the lateral side, and just reconstructing the LCL. And he does it with two small incisions. And he says that's enough. It holds on the lateral side, maybe for a fibula based fixation. And he says it's between the fibula based and tibia based fixations.
Any more questions? There is, I think it's already, we have passed 10 o'clock.
Yeah.
And if anybody has got any burning questions, please shoot in. Otherwise, I think we will, call it a day.
Call it a night.
Yeah.
Okay. So I would like to thank, all the speakers, Murali, Rajanish, and Pradeep for, taking time out on this busy week, as we all are busy nowadays. So, രണ്ട് കാപ്പി. So, I'd like to thank Sujit and Schiller sir for including me in this program. And I would like to invite all of you for our ASK program, just coming in July. And we need everybody's contribution for that also to make it a big success. Anything, Sujit, to add on, please? Thank you, everybody.
Thank you, John. Thank you.
Thank you, sir.
Yeah. Dr. John is in the Vande Bharat train.
I heard him ordering 2 coffees in between while he stopped.
Let's take this opportunity to again discuss about our biannual meeting, which is coming up in Calicut, which Dr. John was discussing about. It's on the 13th and 14th of July. Yeah. Please do note the dates. All of us here, we had around 50 people who joined today. And let's hope that that program goes on well. Dr. Schiller, please put in a few words from your end.
Yeah,
please.
actually, we have been going a little slow on the preparations, but I think in the coming few weeks, we'll try to become a little more active because of some glitches. I was also abroad. I was in UK, got back only a couple of days back. So the thing is, it's not going to be a grand, extravagant event, but we'll try to focus on the talks and the academics part of it. But we have a fairly okay venue, which is Taj, close to the beach in Calicut. And it's essentially a 2-day program. We have tried to include scopies of all the joints, but the theme is essentially instability. So we don't want to cover from A to Z of everything in arthroscopy. So we'll try to stick to instabilities of different joints. And I want all of you to wholeheartedly participate, give us suggestions and criticisms about or whatever, like how we should conduct it. We'll be more than happy to take your suggestions. I'm talking to all the, not only the organizing members, all the other members of the ASK. Whoever wants or has any suggestion, please come forward and put it in the group. And do certainly come, because we have been planning this for a long time. ASK ever since it was conceived or started. This is the first meeting the ASK is having on its own, even though we have supported and encouraged so many other meetings in so many other places. From the messages of what I see on the WhatsApp, I know that it's become this platform of ASK has become really very live, with a lot of people contributing to so many things on a daily basis, and with a lot of people giving their comments and things like that. So I'm sure when we have to also physically meet once in a while, not just on the mobile phone. So and we also need to have raise a little bit of fund for the parent organization, ASK, for it to sustain. So please do come for this ASK conference. We'll be giving you sending personal invitations to people from other states. Pradeep, definitely you are not from other state. You have to be there. There's no, and please ask your friends in Bangalore also to attend this meeting if you can. Okay.
Yes, sir.
So shall we wind up the meeting for today, sir?
Yes, Sujit. Thanks.
Yeah.
Thank you so
So
much.
thank you, Dr. Pradeep Kocheeppan, for finding us time to join and enlightening us with your wonderful talk. Dr. Muralikrishnan, Dr. Rajanish, for the good insights into a difficult, mainly hidden area of the knee, which is often a problem when missed, and the radiologist often misses it, or the treatment decisions are difficult. And in Ask online meetings, we try to select topics which are very focused, which require special attention from the arthroscopy surgeons. So let's hope to have much more wonderful sessions ahead, especially the Ask meeting, which is going to come in July. Thank you all, and good night.